This is a good follow-on from Titus's project, because once you get a healthcare system to implement a new program to make a change, it's important to have an evaluation. So I'm going to be telling you about an evaluation of a national telestroke program that's ongoing in the VA, and hopefully give a little bit of an example of how we've brought some implementation science into that, as well as just give you an overview about the program's rationale and the structure of the program, how we've set up the evaluation with various data sources and developed metrics for the program, and some of the interim results. So my goals are to seek feedback on this mixed methods data collection. So ideas that you all have for how we could make the evaluation better, or pieces that occur to you that would be interesting for us to understand that you're not hearing about. And then also just to increase awareness of the use of implementation science in planning a program evaluation. So I, first of all, want to just recognize all the folks involved in this program evaluation. Especially on the right side of the slide is our project core team, led by Holly Martin, who's our project manager, who, if you see them, remind them to look away from their computer screens and focus into the distance, because they're doing tons of work every day, looking at EHR charts and collecting data and working really hard to make this project work. But we have a great team that's working that represents both IU, Regenstrief, and the VA. So the problem that this program is trying to address is that acute stroke evaluation and treatment is very time sensitive, and it requires specialized clinician involvement. So I wear this little button on my tag which says 32,000 neurons per second. And I wear that because every time I'm in the ER trying to provide acute stroke care and someone is not, moving things along, I just say 32,000 neurons per second. That's how many brain cells die every second that a stroke is occurring. So treatment is extremely time sensitive. The IV treatment for stroke has to be given within 4.5 hours of the patient's last known well time. We can do some other fancy things like pull clots out of vessels now, either within 6 or even up to 24 hours, depending on patient characteristics. But all of this relies on typically neurologists with subspecialty vascular training to make some of these more nuanced treatment decisions. And there aren't enough of those to go around. And VA hospitals admit about 6,000 or even more patients with acute ischemic stroke every year, but most of the hospitals don't have 24/7, 365 coverage for those types of specialists. So the VA has recognized that this is a problem. We also have the problem as a healthcare system that we have some very large hospitals that admit hundreds of stroke patients a year and have stroke specialists. And then the VA, of course, has very small rural hospitals that would be much like a critical access hospital. And the VA, as Titus was talking about, is trying to provide care that is of high quality and equivalent and has little variation across all those different settings. So that's a challenge that the VA has. And a unique challenge for the VA, some people might say, well, why don't you just send everyone to IU Methodist, which is a comprehensive stroke center, which is great in terms of the quality of care, but veterans don't always want to go there. So they show up at their VA hospital for a variety of reasons. They're comfortable there, and there are actually federal laws that limit payment for veterans going to other hospitals. And they know this, and so they're worried about calling an ambulance and getting taken to another hospital. So lots of veterans do show up at VA hospitals for acute stroke care every year. So the program's goals were to improve veteran access to rapid and expert care, and also ultimately to improve outcomes for veterans who have a stroke. So the evidence-based solution for this is Telestroke Care, which has been around for decades, has a strong evidence base, and is typically set up in what we call a hub and spoke model. So that's where there's a tertiary care hospital with all the specialty providers there. There are community hospitals where patients are, and then there's flow of information and potentially patients from the community hospital to the tertiary care hospital and then back to accomplish the acute care. The VA had not really been setting up stroke care in this way, but they do have expertise and a lot of ongoing work in other aspects of telehealth. So there was some foundation already existing at the VA for this kind of work. The VA does a lot of clinical video telehealth from the Indianapolis VA to community-based outpatient clinics around the state. There's telehealth directly to the patient's home. They can do home visits via telehealth. And then there's various kinds of store and forward telehealth where there are images, dermatology images, retinal images being analyzed in a store and forward manner. So the VA has been very interested in telehealth for a number of years. The telestroke model is a new model, though, and this is a virtual telestroke model. So we have a hub of stroke specialists that are located all over the country, wherever they happen to be practicing. And this virtual hub serves the VA nationwide. It operates 24/7 with central coordination, with standardized templates, data capture, standardized training of sites that are entering the program. And they use a variety of technologies. They started out using a VA tool which proved to be ineffective, so now have gone to FaceTime on iPads as the main video strategy. The VA has determined that the end-to-end encryption allows secure use, and so iPads and FaceTime are the primary video technology used. They also have software that allows image sharing, and then importantly, clinical documentation, so that the stroke specialist in Connecticut can be doing documentation for a veteran who's in Puerto Rico right within the EHR for the VA. So far, the first consult was done last October, so we've been active for just a little bit over a year. There are 18 stroke providers that are part of the virtual telestroke hub. There are 20 active facilities. This started out as a project primarily aimed at rural health, so small rural hospitals within the VA. But then the VA realized that there were quite a number of large urban hospitals that also did not have stroke coverage, and so they added those hospitals in. They've allowed them to enter the program. And interestingly, after Hurricane Maria, many physicians left Puerto Rico, and the Puerto Rico VA, which used to have stroke specialists, became an isolated facility with no stroke specialists. So the program is also covering the Puerto Rico VA now. There are 5 facilities currently in training, and as of last Friday, there were almost 500 consults that had been completed. They plan to enroll 15 additional facilities in this fiscal year, which kind of gives you one of the challenges, an idea of one of our challenges, which is the program is growing so rapidly. We've had to really scale back pieces of our evaluation since they haven't increased our budget for the evaluation proportionately to the size of the program expansion. We've had to sort of make sure we're triaging and targeting the really core data that we need to collect. This is just a picture of what it looks like from the patient end. So you can see the iPad there on the cart. And that's a telestroke doctor who's doing a simulation. This is a simulation training. So they can see the patient, they can zoom with the camera, they can pan, they can have the staff in the ER move the camera around the room so they can see the patient better, and they can talk directly to the patient or to the staff that are in the emergency room. This is the general process flow for how one of these consults happens. They are targeting the consultation right now for veterans who present within 8 hours of symptom onset, although that may expand as the evidence base for treatment expands to longer time windows. The facilities request a consult via a 1-800 call, and the telestroke MD then connects via FaceTime with the staff in the local ER. They direct ongoing investigations for the patient, like stat head CT, labs, nursing orders. They review all of those results, they recommend the treatment, and then the local facility executes the treatment recommendations. That all has to be done within 60 minutes of arrival. That's at least the Joint Commission and Brain Attack Coalition target treatment time for stroke. And then a decision is made about whether the local facility can care for the veteran there or whether they need to be transferred elsewhere. Our evaluation is a 4-year contract. This is an operational project, not a research project. It's considered part of program evaluation and quality improvement for the VA. And our funding comes primarily from the Office of Rural Health and the Office of Specialty Care, which includes both neurology and the emergency department for the VA. And our activities are largely, you can see in this year and the current fiscal year, collecting program data and producing quarterly and annual reports. And I can assure you, and those of you who have done contracts for other organizations, that is really a different ball game for a principal investigator to have to generate a quarterly report for someone as opposed to an annual report for your research grant. So there's a lot of activity that has to be streamlined and kind of automated as best as possible to make that happen. This year, we also have some work to do helping the program train their staff, doing external facilitation for the facilities. We're going to work on developing automated program metrics so that after this evaluation is done, the VA will have a means of evaluating this program in the future, and then we'll begin conducting some pre-post analyses that I'll tell you about at the end. So here's an idea of the different places that data come from for us to be able to conduct this evaluation. And like any evaluation, you produce these reports, you produce metrics. It seems pretty straightforward, but the devil really is in the details. So we get quite a bit of our data from the VA Central Data Warehouse. This is keyed to the ED and the inpatient ICD-10 codes, and we get things like their arrival dates and times, what time they were admitted, what was their discharge disposition. We get other things that we can extract with simple text extraction from SQL using Telestroke note titles, making sure that we're finding all of the consults that we think are happening, and also the names of the providers that are doing those consults. And then we put that together with an old-fashioned log. So the Telestroke program keeps track of a daily log of the number of consults and where they're done and what the patient's name is. And so, not everything is perfect. And so we have to combine those two things to develop really our cohort of interest, which is patients who have a stroke diagnosis, either in the emergency department or the inpatient setting, and also patients who have a telestroke consultation. We can't rely solely on diagnoses because about 40% or 35% of the telestroke consultations do not result in a diagnosis of stroke or TIA. So if we rely only on diagnoses, we lose those. We then do a chart review of the EHR, again, collecting some data that are fairly structured, like the time of the first contact of the telestroke system, but also unstructured data. And I've highlighted patient last known well time. That is the real unstructured holy grail of stroke research, because everything keys from the time the patient was last known well, and it is not documented in a standardized fashion. And in fact, often documentation varies. So if you look at the nurse's note, you'll get one time last known well. If you look at the provider's note, you'll get another one. If there's a neurology consult, you may get yet a third documented time of last known well. So that remains a complex piece of information that is really fundamental to much of stroke quality assessment and certainly to this evaluation. And then we finally also in this evaluation are doing interviews of patients and surveys of staff at the sites. So we ask the patients about their technology use, the experience of having a telestroke consult, and their satisfaction. And we ask the site also about their technology experiences and satisfaction. Those things take place at different times. We want to capture the patient's assessment as soon as possible relative to the time of the consult, but recognizing that they've just had an acute event, or some proportion of them have just had an acute stroke, we time that call for about 2 weeks after the consult. Surveys take place at baseline, and also then at 6 months after program participation is the first time we do a satisfaction assessment. So here's a little bit about how the data kind of flow into the program, and it really does become kind of a complex task to orchestrate all of this coming in. So I really have to give my hats off to Holly, who's really helped us organize this and make sure that these things are all working. So we have team members that look at this log that's done daily or every other day to assess patients that have recently had a consult. That's because we need to enter them into our scheduling database to make sure we are calling them, perhaps even before we've extracted their administrative data from our central data warehouse. So the central data warehouse data comes in every month. We could do it more often than that, but for now it seems to work to pull that data every month. So we're pulling prior month's data. So we're looking at the discharge diagnosis from the emergency department and the discharge diagnosis from the inpatient stay, if there is one, to identify those stroke patients. We then do chart review, again, in this retrospective fashion, and that's something that all of our team members are doing every day, making sure that we're keeping up so we can generate our quarterly reports and really identify, first of all, the patients who are coming in within 8 hours of their stroke symptom onset, since they're the main group for which we have interest in evaluation. And then there are these random surveys that are going out for sites that are joining the program, sites that have been in the program for 6 months. And so those are just happening randomly based on when sites have entered the program. So lots of data flowing back and forth in different formats and ending up in different places for our evaluation. We worked in the first year of the program with our national partners to develop program metrics, and these are just a small group of them, but these are really some of the more important program metrics, and some of them are the metrics that they are reporting to national partners on a quarterly basis. So some of them deal with access, some of them deal with the quality of the care that's being delivered, and some of them deal with patient and provider satisfaction. So I'll show you some of these results in just a minute. We also collect a lot of other data that are of interest to try to understand how the program is working and what the patients are like who are receiving stroke consults or who are eligible to receive these consults. We look at different outcomes of care, different processes of care that can help sites identify why their treatment times might be prolonged, and then some other questions that we ask about patient and provider experience. So there's quite a bit of, if you are wondering about it, just ask in our time at the end, because we're probably collecting something related to something that you might be interested in. We intentionally tried to set this evaluation up so that it matches some of the other work that we're doing within the PRISM query at the VA. And so even though this is not an implementation research project, we wanted to set it up using some of the similar questionnaires and some of the similar methods that we do in the other data programs that we have. And so Teresa and Edward really have been key in helping us think about these things. And this is just some examples of where we're collecting this type of data. So we think a lot about the inner context, the context at the facility and what's going on there, and what kind of capabilities they have for imaging tests, what their local transfer rate might be, unstructured data, like are they getting other local neurology consults that are not from stroke specialists? What are those consultants recommending? That kind of thing we collect. We collect things about the site providers themselves and what they think about their improvement culture, what they think about the readiness to change and the buy-in from different parts of their organization, like radiology and nursing staff and things like that. Edward and Teresa have developed a measure of clinical champion function at the sites. And so we ask the national team who knows the site providers, and then we ask the sites themselves to reflect on the clinical champion and how that clinical champion is doing at the site. And then we have quite a bit to do with data feedback. So the national team is actually feeding the data back to the sites. We help them prepare the data. We listen to their conversations and record comments about how that's going and get information about different sites and their uptake of the data that way, as well as collecting additional data from the surveys. So here are just some interim results. These mainly deal with our results from fiscal year 18, so just ended at the end of September. And in that first year of the program, there were 350 total consults. At the participating hospitals, there were 723 stroke admissions or stroke ED encounters that we had to review. So it gives you an idea that about half of the potential stroke patients were receiving a telestroke consult at those facilities. Here's one of the core metrics, which is what % of people who arrive within 8 hours actually receive a telestroke consult. And the line represents the fiscal year average for each site. The colored bars are just the different quarters. So you can see there are some sites that have just entered recently. Here's Washington, D.C. They only entered in Q4. Shreveport entered in Q3. And then there are some sites like Augusta, Maine, or Martinsburg, West Virginia, that have been part of the program since the very beginning. And overall, the sites seem to be doing quite well. So about 3/4 of patients who should be receiving a telestroke consult because they have a stroke and they come in within 8 hours are receiving one. Overall, about 34% of all stroke patients arrive within 8 hours of last known well. So this gives you a sense of how the programs are doing. And it gives you a little idea also that what I anticipated might happen is that sites would struggle to identify the patients at first, and then their performance would improve over the quarters. But you can see that doesn't really happen. Some sites are really good at the beginning. Here's, Washington is already, their very first quarter, they're already at 70%. And then some sites like San Juan is not having as many patients that could be eligible for telestroke receive a consultation. Shreveport's another one that was kind of struggling at first to identify the right patients. But these data allow the national program to work with those sites individually then to try to improve their uptake of the program. Another metric that is a difficult one to meet is they would like the telestroke consults to be initiated within 10 minutes of patient arrival in the emergency department. So this is tough to meet, and sites are struggling to do that. The median time you can see so far is 25 minutes, and only about 20% of patients are having their consult initiated within 10 minutes of arrival. Some sites do better than others, so this gives us a chance to identify sites maybe that are doing a little bit better job and trying to learn what they're doing and spread that knowledge to other facilities. In fiscal year 18, there were 54 patients that received TPA via telestroke. So they received IV thrombolysis, or there were 53 out of 54 that were eligible. So almost every eligible patient was treated. There were actually no patients that had a significant intracerebral or systemic hemorrhage. That's a really remarkable quality rate. I think it speaks to the quality of the providers that they have engaged. 33% were treated within 60 minutes of arrival. So that's not a bad start for treatment within the 60-minute time frame. And the median door-to-needle time for thrombolysis was 71 minutes. So for patients that are being treated, I think we have evidence that the quality is actually pretty good for this stroke care, certainly on par with other kinds of Joint Commission accredited hospitals around the country. Patient surveys are a big part of what we do, and I think it's a really important part for us to know what the veterans' experience is like when they receive one of these telestroke consultations. So these data are including some actual data from this new fiscal year. So I think we just pulled data from Monday. At that point, there were 389 total consultations. It turns out about 335 are eligible to get a call, meaning they didn't die, they're not still in the hospital, they're able to be reached. We've been able to complete 150 of those. You can see the reasons why we haven't completed. Mainly, we just don't reach the patient after 3 attempted calls. Sometimes we reach them and they really don't recall it. In the setting of this acute event and perhaps other medical comorbidities, they may not really recall the telestroke consultation. So we have 130 veterans that we've been able to actually complete a survey and do our satisfaction questions with. This gives you an example over the quarters of how patient satisfaction has changed. And it's an interesting way for us to look at the data. Overall satisfaction is very, very high. So the green line is the national average. This is a truncated y-axis here. It's a 1 to 7 integer scale that they're asked to rate these questions about how satisfied they were with knowledge and skills of the telestroke provider and with their experience receiving telestroke care. And so it's right at about 6.5 out of 7 patient rating. It is interesting, though, we can see that there's one site, Clarksburg, that seems to, the patients are a little bit less satisfied. So again, provide some information to our partners to try to figure out maybe why the telestroke program is not, the veterans aren't as happy in Clarksburg. The rest of them are kind of clustering around that 6.5 mark. But in general, patients have been very satisfied. And we have some interesting quotes from the patients. One of the veterans said, about the iPad on the stick, that he felt like he was in Star Wars, and was very happy. So we have lots of good, juicy quotes as well there. We asked the patients about the technology, and you can see that they really feel pretty good about the technology. Over 90% said they could see and hear the telestroke doctor clearly. About 75% report they were able to ask questions of the doctor and to understand what the doctor said to them. So we've been pretty happy about that. The site physicians themselves, who are the other end of the telestroke consult, are pretty happy as well. And so we have 3 questions for them. They rate these questions on a 1 to 10 scale. And the national average for site satisfaction is 9 out of 10. It's a pretty high rating. They're quite happy with it. Most of these sites were not doing any kind of acute stroke care before. We asked them about the technology, and they're actually quite happy with the technology as well. 91% either strongly agree or agree that they're satisfied. The one piece of technology they don't like, which anyone who works in the VA could have predicted this, is the electronic consent form that is supposed to be done. That remains a difficult thing to accomplish, and doctors don't like it at all. We've also conducted some interviews with the hub providers, and we've been interested in the extent to which they feel that they've developed as part of a virtual team. And so we asked them about that and about tools that they might have used to help increase a sense of teamness, even though they're located all over the country, and what might enhance or diminish that sense. And we're going to be presenting these data in February at the American Stroke Association meeting. Really, we were surprised a little bit, I think, to see that they really had quite high levels of trust between each other, even though they might not have met. And several people said they actually felt more a part of a team with these virtual people that they don't meet than they do with their local colleagues. Some of that is because they have a pretty robust case conference call every week, so they have an opportunity to discuss difficult cases. There's a sense of transparency that I think the national program has been really good at developing. And they also got the telestroke providers engaged in the program tasks. And this, even though there were technological hurdles, being engaged in solving those problems, I think helped people feel like they were really a part of a team and really good about what they were doing. Our next steps are to conduct a pre-post analysis. We have data for the year prior to program entry for any site that's entered in the first 2 years. We'll be also planning a business case analysis, and we're working with some colleagues in Nashville to plan a merit review grant about the quality and clinical impact of urgent consultations and transfer in the ER. So that's, I know we're almost at time, but that's just a snapshot of our evaluation. I would love to hear any comments, questions that you might have about it, Pete.
So really outstanding work and so impactful. So congratulations and kudos. I mean, that's amazing. So actually I just had a couple of thoughts as you were going through, just to throw them out. One was that I just had a quick question, I guess. So that comment about the electronic consent, mm-hmm. Do you get the sense that that's slowing down time to needle? And if it is, then, you know, would it be worthwhile just as a simple maneuver to just, you know, do paper and then follow up with electronic? Have you all talked about that?
Yes, and that's exactly what's recommended for the facilities. This is a problem for the telestroke program and for the VA at large, because the legal people have decided that the consent does have to be documented, but there has been a determination that paper consent that's scanned in is appropriate, and so that's actually the recommendation.
That's great. I mean, I think, you know, anything that speeds time to needle, as you say. And so then the other question, I guess, along that line, and this is more just my ignorance, and I'm curious, is proud of the lack of serious bleeding complications, but is there some need to tolerate a bit more of that in order to increase the time to getting people treated, or is that inappropriate?
No, that's a good question, and I wondered if someone would ask about that. And I have my own opinions about it, so now I have to say this is just my opinion, not the opinion of the VA healthcare system. But I think that one reason that happens is because, to Steve's point, we had a big debate about how do we define that quality metric. Do we use, purely the TPA drug insert information, about absolute contraindications, or do we allow clinician documentation of here's some reason that I didn't give TPA? And we allow the latter, which follows what the Joint Commission does. So any reason they say they're not giving it counts as a reason, and they come out of the denominator. What I think that means is that patients who potentially could be treated are being taken out. Patients that maybe have a higher bleeding risk but might still benefit. So probably there are some patients that could still benefit that we're not treating. At least for those that we are treating, we have not seen any that have been treated inappropriately, and we haven't seen any bleeding. And 53 is a pretty good number.
Yeah, I mean, the numbers are great. I mean, so that rings true. You know, the idea that we generally, as a sort of clinician culture, are more comfortable with errors of omission rather than errors of commission. Right. But I think it speaks to what really is going to lead to the best patient outcomes, and that's worth pursuing. That's interesting.
Right. Steve? I know we're late. Okay.
Okay. Well, then I'll ask it really quick. Do you think there is a learning component in which your local docs are beginning to develop expertise through the telemedicine, expertise or confidence, and are you measuring that?
We are measuring that. We haven't looked at it yet. We plan to analyze it by February and present it when we're out at the national meeting. But yes, we're asking them at baseline about their confidence, and we're also asking them not only about stroke care, but do they feel it's improved their confidence in managing other kinds of neurologic conditions in the ER. So we'll see if that sort of spreads out and diffuses a little bit.